Hello and welcome everyone to today's webinar. It's going to be part one of persistent pelvic pain with Sherburn. So my name is Carlos Bello. I'm the physiotherapist and team leader of one of the pain management services of Eastern Health. I'd like to introduce also the members of our pain service. So we've got Michelle Wallace, OT, Alison Thomason, OT, Eddie Purnell, physiotherapist, Sue Yenkin, health psychologist, Louisa So, consultant pain specialist, Bridget Callanan, AHA, and we have Jeremy Swirling, pharmacist. So this is part of a series of webinars called the Pain Management Clinicians. These are designed to support doctors and allied health practitioners to develop their knowledge and skills in the management of complex pain presentations. So we record our webinars and post them for future reference. We've previously done this year pharmacotherapy in chronic pain. Just a couple of weeks ago, we did borderline personality disorders in chronic pain and others. So I'd like to introduce our presenter, Margaret Sherburn. So Marg is a senior lecturer in physiotherapy in the Department of Physiotherapy at the University of Melbourne and is a clinician in private practice. Her main areas of research are conservative management of pelvic floor dysfunction in women with pelvic pain, prolapse or incontinence, the use of real-time ultrasound as a rehabilitation and a measurement tool, and the role of exercise for women. She is a continence and women's health specialist physiotherapist as a fellow of the Australian College of Physiotherapists. She is the immediate past editor of the Australian and New Zealand Continence Journal and is currently the Journal Editors Review Committee. So great to have you, Marg, and thank you so much for taking the time with us, especially with the double delight, and I'll hand over to you.
Thanks, Carlos, and thank you very much for the invitation to speak to you all. Carlos, can you just check the volume is fine? Can you hear me? Give me an indication. Thank you. So I work with Carlos at the in private practice, so we have a connection outside of the Eastern Health, and that's how I've come to be invited, which is lovely. So when he asked me to talk about persistent or chronic pelvic pain in an hour, I thought, no, this is not possible. So I actually requested that I have 2 sessions with you, and it was then easier to divide up into assessment versus treatment. But I also didn't want to talk down to anybody. You're all clinicians, you're all working hard in the area, but also to give some indication to people who are not physios as to what our thinking is and how we go about is a part in pain ever since our very favourite physio researchers, Lorimer Moseley and David Butler, taught us all about that in the early 2000s. But now it's in the standard definition. The rest of the definition talks about associated with or resembling that associated with actual or potential tissue damage. So we still have a biological component or a pseudo-biological component, and it's up to us as the clinicians then to define and decide what's happening in our patients. But if we go back to that second and third words, unpleasant sensory definition, we already know that our patients are going to have a response to that, which goes under our very old-fashioned fight, flight, or freeze. And so we're going to be looking for those characteristics in our patients right away because of the unpleasant nature. Now, we might think that fight, flight, and freeze is a sudden hormonal response to a dangerous situation. But the body can still be flooded with those hormones when at a lower level over a longer time, causing all sorts of problems over a long period of time in chronic pain. So let's look at what happens in the body with pain. And this is a very famous diagram looking at the top left of the diagram, the old Descartes understanding of nociception, or pain in those days, up to the brain, where pain was an input into the brain. Now we know pain is an output of the brain. The noxious stimulus passes to the brain. We have a pain experience in the brain. And that experience is from our prior experiences, our attention to pain, our mood, the neurochemical structures and changes in the brain, genetics, and sensitization of the whole system. So you can understand why pain is so difficult to treat, because it affects so many different parts of our body. So to go back to our definition, if we look at chronic or persistent pain, it's a very simple definition. It's that pain which lasts for more than 3 months. But there are implications, aren't there? Because then when we get the syndromes associated with this lasting pain, we then start to look at pain as the sole complaint, or is it just the leading complaint in amongst a whole lot of biological problems? So that's up to us when we take our history to understand that. But I think when people or physios, doctors, anyone who's not working in the field of the persistent or chronic pain, where normally we perceive pain as a disease in its own right, switching from a diagnosis or an etiological framework to a pain framework is quite difficult to do. And we note that even in other referrals that we get, they're always the etiological problem rather than the pain in its own right. So to go back to now onto adaptations to persistent pain in our body, we have peripheral and central. So I won't spend time on this because I want to get onto the clinical stuff, but just as by way of background, getting used to my voice and how we're going, you've got the neural adaptations being neural sprouting, neurogenic problems such as inflammation, the peripheral and central sensitization, hyperalgesia and allodynia, things you all know and love. And then we have the central, the brain CNS changes, and it can be many. It can be faulty descending inhibitory fibers, the responses, thoughts and beliefs, a better neurotag in the brain. And for those who aren't familiar with Lorimer Moseley's neurotag, we talk about the fact that there is no pain center in the brain. Pain is distributed, or the reception of, and the output of pain is distributed across the whole brain. So if we have this neurotag that is the response to pain, it gets reinforced all the time with persistent pain. And then, of course, we've got the neuroplastic changes occurring, particularly in the cortex, with our changes to our logic and our logical interpretation of pain. Remember also in chronic pain, it's not just the nervous system. Certainly we have the peripheral nervous system, the central nervous system, and the autonomic nervous system. But there are changes in the motor system. The muscles and joint responses to pain are, this is where our flight and fight mechanism is visualized in the tense postures or the low tone postures. Our endocrine system, our hormonal system, our immune system, and we know more and more about the glial cell roles. So the whole body is changed. It's up to us to sort out where to tap into the changes. I thought I'd just have one quick slide on visceral pain too, because if we're talking about chronic pelvic pain, we now have orchic pain. We have bladder, in women, uterus and bowel, which don't have nociceptors in them apart from the urothelium of the bladder. So nociception isn't equal to visceral pain. So where does the pain come from in viscera? Distension most commonly, And we know so many of our patients talk about, oh, I feel bloated, or the pain occurs when my bladder fills, or I don't have a message to go to the toilet to do a bowel motion, I get pain in my bowel. So that's the interpretation of pain from viscera. Also, pain may be expressed not as pain, but by autonomic reflexes such as nausea, sweating, and all those vagal symptoms. And remember that we certainly get referred pain back to the somatic system, and often hypersensitive. We should ask ourselves, well, why does pain persist? And this can help us in our treatment as well and our assessment. Pain persists because the body thinks it's still unsafe. So Mosley and Lester Jones have reported that, and I quote them, anything that would lead the brain to conclude that the threat to tissues has increased increases the pain. Conversely, anything that would convince the brain to conclude that the threat to tissues has decreased will decrease the pain. So there's a threat. And as an assessment, in our assessment, we need to find out what is the threat that the patient is afraid of. Now, that is really difficult because in chronic pain, the threat may have been back in childhood. It may have been bullying. It may have been the anxiety of the birth family. May have been death of somebody important as a child that the person can't recognize yet, or may never recognize. And we don't want to go down rabbit holes hunting for why the pain persists as a threat. But maybe during our assessment, we could keep that in mind so that we provide the patient with anything that can lead towards their sensation of safety. So I've got a couple of slides now that might sort of seem like they're odd and not fitting in, but in a short lecture, that's the only way we can get around a few topics. So non-cyclical chronic pelvic pain, talking about pain that's not associated with the menstrual cycle. So generalized chronic pelvic pain, the correlates of them are really interesting because I just mentioned in the previous slide things like childhood traumas, but nothing beats psychosomatic symptoms as the most highly correlated factor with chronic pelvic pain. Now, this is an American article, and I noticed that they use psychosomatic still, whereas we use functional problems. So interpret that the way you will. But association with chronic pelvic pain of things like fibromyalgia, migraines, IBS, those functional syndromes are the highest correlate with chronic pelvic pain. So we need to think about those things more so than sexual abuse, depression, anxiety, and look where endometriosis is, which is probably the most common chronic pelvic pain syndrome that we deal with. Sure, if you have endometriosis, you're twice as likely, nearly, to get or to be associated with chronic pelvic pain and vice versa. But that's nowhere near 8 times the functional syndromes. The ones that we are most commonly deal with are, as I say, the IBS, the migraines, fibromyalgia, etc. Now, to look at that in context, I thought I might now show you, and I'm going to share my screen, so I have to stop this share and start another one. Bear with me a moment, of some of the referrals that I have seen from Eastern Health, thanks to Carlos just giving me an idea of the types of patients you see. And when you look at them, they're all redacted names and everything, so it's all safe. I want you to look at the what the referrals say about the bio problems versus the psychosocial problems. So let me go into that, if you'll give me a moment. Okay, so here's one. This is a referral for chronic pain secondary to endometriosis requiring opiates. I'm sorry, I can't read it all because the images of you all are on the right-hand side of my screen. If I miss some words, bear with me. Recent laparoscopy at Angus, required fentanyl and ketamine infusion post-op. So I want you now to think back to the first slide I showed, the definition of pain. Unpleasant sensation, it involves emotion. So in this, and also thinking about chronic pain, pain is the major, pain can be considered the diagnosis in and of itself. So here we acknowledge that by saying it's chronic pain secondary to endometriosis. We've got the medications, we've got the surgery, but that's all. Now, this referral goes on, and I'll just quickly screen through, you don't have to read it, but there's 5 pages of stuff, screening tools, but nothing that would give us any clue as to the psychosocial side of things. So next referral is one to the chronic pain clinic. Likely mild endometriosis, ongoing pain since surgery, admitted to gynae ward for pain management. Examination, no cause found. So this is a good one for chronic pain, isn't it? It's secondary again to an endometriosis, a biological or an etiological diagnosis, but pain is what the patient's being referred for. There's a start, there's an acute start, it's since surgery, but we don't know any more than that. Maybe the surgery was a trigger for something that was ongoing. But no cause found, so pain is the primary diagnosis. This was a 1-page referral, as is the third and last one that I'm just about to show you. So this one is through to the referral to the chronic pain specialist. A more than 12-year history of chronic lower abdominal pain. That's the primary diagnosis. This person I looked earlier was age 30 now. So if it's more than 12 years, this problem began in her teenage years. So a very significant portion of her life, she's been in chronic pain. She's had laparoscopy, and only a single lesion of endometriosis was found. So here we have a diagnosis of a single lesion of endometriosis. So we may or may not, we may have some views about how much endometriosis is affecting her. She's had dysmenorrhea, she has a marina in situ, and she's on long-term oxycodone and Panadine Forte for more than 10 years. She's had an ultrasound of her pelvis and colon with nothing found. Her past medical history is bipolar disease with a history of self-harm, depression, and migraines and POTS. So this referral indicates a really large psychological or emotional component to a history of chronic pain. So we've got a really good picture in this referral of what the patient is going to be here. So why am I showing you this? I just want you, when you receive a referral like this, to understand that if someone's writing a referral, they're going to be writing the most important things to them. So in this last referral, there's physical, surgical, psychological, and functional correlates with this this major diagnosis of lower abdominal pain. So I was really just saying what a good referral that last one was, because it had a bit of everything. I had a really good idea of where to go with that patient. Then I shared screen, but there was a bit of silence because I had to stop one screen and start another one. So I thought before I go on and look at pain just as chronic pain and as the diagnosis and the etiology of its own, I thought I'd just quickly put up a single slide again of common pelvic pain conditions that you will all get referred, and you can just read the list and it's obvious. I'm sure you've treated all of these types of patients. And you note that I'm a fairly female focus here today. I have just put one token gesture to the male, persistent pelvic pain at the bottom. but because there's so many gynecological and sexual problems with females, that the focus is on this today. Since endometriosis is such a common problem, I wanted to point out another single slide about some researchers done looking at the change from an etiological diagnosis to a symptom diagnosis, particularly a pain symptom. These authors, again from the United States, started looking at endometriosis from another way, looking at the interacting elements that influence the pain of endometriosis, not the lesions of endometriosis. And in their researches, as a summary of it, things that influence the pain are menstruation, uterine and ovarian function, hormonal function, birth functions, delivery and parity, and fluid within the pelvis. They also suggest that we should be looking at all of these factors above, and whether and how the innervation of the plaques, the endometrial plaques, become sensitized by these factors, which in turn then affect the central nervous system and the sensitization that occurs. And so they argue the case that we should in fact be looking at the pain of endometriosis and putting more research evidence into that, rather than focusing on the plaques themselves. So again, looking at endometriosis as a central sensitization issue rather than a biological issue as much. So with all that in mind, now we come to the core of what I wanted to talk about, I guess. That is a different way of assessing pain. And this is for female pain. Lester Jones is the author of these. And I know Carlos has mentioned the Lester Jones triangle to you in the past. So you will understand that we have local factors, regional factors, and central factors when we have any of these chronic pain conditions. And specifically, Carlos, I don't know whether you've actually gone into all the detail here, but I'll quickly go through the factors in each of the corners of the triangle. But because you'll get the PDF of this talk later, you'll have this for reference anyway. So how do we get pain locally? Well, it's somatic. So we have tissue deformation. That's compression or stretch or torsion of any tissues. And if we're talking, I'm going to give you a case study of vulvodynia in a moment. If we talk about vulvodynia, well, provoked vulvodynia, we have compression of the vulva against tight jeans or any sorts of pants. We have stretch or torsion of the tissue during sexual intercourse, causing pain. We have chemical stimulation. If we think of the vulvodynia as being an inflammatory disease or a pain problem, we can have inflammation, or it could be ischemia to the area. So there's lots of things that could cause local pain. When we start looking further than the vulva, we have convergence onto visceral organs, bladder, bowel, uterus, as well as further out of the vulva on the body wall. We can get then altered tissue loading as people change their postures, as people have used their fight or flight mechanism and they tense up when they are fighting the problem, fighting the pain. And that, of course, is going to change the neurodynamics of the area. We're going to get sensitivity of the peripheral nervous system. We could get neuropathy or neurogenic inflammation. Up in the central modulation, with prolonged afferent input, we are going to get prolonged pain back there. It's going to, we're going to get enhancement of transmission. We're going to get neuroplasticity over time. Why do some people get that? Well, if we take the threat model that I mentioned before, what's causing what's the threat that the woman unconsciously perceives? It may be their previous pain experience, their prior knowledge of pain, trauma, their previous response to trauma, or other life adverse events. And then we've got the cognitive emotional side of things, psychological stresses, social stresses, the moral meaning of pain, even fatigue, or is fatigue a cause or effect? So when you've got a model like this, it really makes it easy to assess a patient. And if you do it in front of a patient, it's very easy for the patient to see that assessment and take it home with them. And this is one of the ways I commonly assess a patient on if you can look in me, rather than the screen, up in the little picture of me, an assessment sheet like this that I can photocopy and the patient can take home as a living document. Now, just recently, there's been well, it's currently happening, the Australian Continence Foundation Conference. And one of the speakers last week was a physiotherapist from Canada who didn't use the Lester-Jones triangle, but had created her own using the biopsychosocial model. So her the biological factors, all the biofactors, whether local or regional, were lumped together in the bottom right-hand pink diagram that you can see there. And she separated out the social factors and the psychological factors. And this may be more an appropriate triangle for psychologists to use to emphasize their scope of practice, whereas for physios, our scope of practice is more than biological. So I put that in as an alternative triangle that other practitioners might be able to use. So let's talk about vulvodynia briefly. Vulvodynia is defined by the International Society for the Study of Vaginal Disorders is vulvar discomfort, most often described as burning pain occurring in the absence of relevant visible findings or a specific clinically identifiable neurologic disorder. Really, that doesn't tell us a lot, does it? It's vulvar discomfort. So pain is the primary feature of vulvodynia that we as clinicians are going to be treating. So then we go back to our definition of pain and all the things I've talked about in the last 20 minutes or so. So yeah, you might think, well, is vulvodynia in fact an etiological definition or a symptom classification? I would definitely go with symptom, and that then guides my assessment and treatment of vulvodynia as well. Of course, we can subclassify vulvodynia, and you all know this is generalized.
I think we lost her again. I think she should be back on pretty soon, but just make sure not to wear tight pants, guys.
In the vestibule, and to think about it as have I gone? Can you hear me?
Yeah, we just got you back. We lost maybe about 10, 15 seconds.
Okay, so I'm just talking about, you can see it on screen. I was really going through this, that we need to think about, we not need to, this is an alternative view. Is it an inflammatory disorder? And their definition of deciding on a diagnosis of vulvodynia is previous history of more than one urogenital infections, either UTI plus or minus a thrush plus or minus sexually transmitted infections, plus an antecedent history of some sort of allergy like hives, insect stings, seasonal allergies, plus an antecedent history of anxiety, particularly they say fear of harm rather than actual harm, and depression. So again, this helps us with our which way to go with our assessment of vulvodynia. Maybe if we see a very highly inflammatory biology when we observe the tissues, we can then ask about antecedent history of these three items. And then we can determine a treatment according to that. I put this in because there's a diagnosis of provoked vulvodynia. The Friedrich's criteria: pain on touch, tenderness to pressure, and varying degrees of erythema. How do we test things? The first one is the Maranoff dyspareunia scale. Dyspareunia. I thought we were talking about vulvodynia. So already the associated clinical tests for vulvodynia are a dyspareunia scale. It's on the next slide, just in case you've never heard of it, and you may not have. So in other words, vulvodynia and dyspareunia are closely interlinked. Of course, we then do this cotton swab test in the visual examination. So the Maranoff dyspareunia scale is very simple, a 4-point scale of no pain on sexual intercourse, some discomfort, and it's the prevention of intercourse that's the severity. There's the severity of dyspareunia. Of vulvodynia is gauged on. So I actually sent Carlos a vulvodynia case study, which he's going to send around to you. It was a case study that we did in another group Zoom study I did recently. But when you get it, I want you to see.
I think so. Margie's going to be Margie's sending me a 5-page case study, and I think what she was going to ask us to do is to, maybe she's here. Oh, there she is.
I'm here. Sorry, I'm so sorry about this unstable internet.
It happened. That was my whole September.
So I'll get my share screen up again. But basically what I was saying was that a big, long, linear case study like that, a long history like that, takes a long time to read. We may or may not need all of that information to treat, but if we do, it's good to take it. But I'd also like to show you the case study on the Lester-Jones triangle, which I showed you on the screen a moment ago. I just put it up to the screen. Let me show it to you. So 5 pages could be reduced to 1 page that a patient could take home. So we can see that the local factor, the reason she's come is vulval pain. She's described inflammatory symptoms, a gradual onset, and secondary dyspareunia because she has been able to have intercourse pain-free in the past, but now is unable. So on a Maranoff scale, she'd be stage 4, totally unable. Regional factors: she has bladder problems, bowel problems. She can't exercise because of the sweating and friction on her vulva, and her postures are tense, crossed postures with apical breathing. So she's really she's fighting it. She has anxiety, particularly in stressful situations, and depression. Her social history is she's working part-time and studying a law degree, but the social situation is very stable, is with her parents and has a boyfriend. Her goals, we can write on this same page. She wants to understand her pain. She wants to gain some strategies to manage her pain, and she wants to have penetrative sex, and she wants to exercise without pain. So it's all there. Now, if she takes this home, she can think about, which is more important to her. And I talk to patients about, and I don't know whether, Carlos, you've talked about with your team about this, think of each of those corners of the triangle as being like a speaker from the corner of your living room, beaming volume out into your room. Which of those speakers might have the most volume? Do you think, and this might be something that you could think about during the week, because we'll come back to this case study next week. Which do you think is the most important, might be the most important for this woman? Of course, we'll all make our own judgments on that, but there's something that we can give the patient to take home and consider herself. All right. So now I'm just going to go back to the my PowerPoint.
Mark, what I love about that triangle, Lester's triangle, is that it gives you, like a structure for assessment, but also, then actually directing your treatment. But it's really interesting that you talk about speakers, because what I'm a little bit more like graphical, like mathematical methods type of thing. So I sort of have like I draw a circle in the middle, and then have a line of like small, medium, large of severity for each of those points of the triangle. So the triangle will change its shape based on, whether there's severe or moderate or minimal, like local factors. And then therefore that's how much time you spend on that.
Yep. That's another way of doing it. I'm sure that anybody else who uses it would have their own way of getting the volume or the influence of that particular corner of the triangle on the whole pain scenario. So I must say that I thought that that the audience today would be more physio focused. So these comments are pretty physio focused. When I use our scope of practice, I mean physiotherapy scope of practice. So I want each of us in the on the Zoom today to ask ourselves, do we concentrate on the bio component of assessment, because as physios, this is our scope of practice, and do, say, doctors and psychologists expect us to do that because that is our expertise? And if we're working in a multidisciplinary team, which is what you are, that the treatment is shared amongst the different practitioners. And so it would be unsuitable for me as a physio, if I were in your team, to delve too far into the psych or talk about medication too much, or what might happen surgically. So this is something that I'd like you guys to understand, each of you individually. It doesn't have to be an answer. There's no special answer, but it's a consideration. So again, from a physio point of view, goes, how comfortable do you feel to address the psychosocial components? And if you don't feel comfortable, do you have someone to turn to? I could ask the same question of the psychologist. How comfortable do you feel addressing the biological components? We each of us have a bit of an idea of what the other clinician expects and understands, but can you back up the advice that other people are giving in your team? So if you're not comfortable in any areas, it's up to you then to make yourself comfortable, educate yourself, etc. So in any patient, it's a good idea then to determine which is dominant, the central or peripheral symptoms, so that you can direct your treatment. It's no use thinking or feel most comfortable with the biological component and always go for the issue is in the tissue, and then always do your stretches and your myofascial techniques and other things because that's where you love to be. But in fact, not understanding that that's driving the patient to reinforce that this is a biological problem, and everybody else who's talking about their emotions is on the wrong track. And so you get the patient a bit offside with the other practitioners if you emphasize your own area to the detriment of others. So determine which is dominant, but then keep in mind the other members of the team. Remember, as physios, there's a bit of a warning to physios, and make sure you understand what central sensitization is and versus neuropathic or inflammatory pain, because we don't prescribe medications. So we need to get someone else in our team if it is a neuropathic and inflammatory problem. Now, the last one is one that I don't have an answer for, but I think it's one that and I'd really like some input myself on how to manage the long-term hypervigilant, ruminating type character, because we know that these are real barriers to success in chronic pain. So how do we manage these? So in the vulvodynia case study that you're going to get and you're going to work on during the week, I want you to consider, it's not in the case study in particular, but I'd like you to imagine, what if that person also had on top of her symptoms, hypervigilance or rumination, because they can certainly limit the progress. Before I go on to the very last slide, which is really an introduction to next week, I wonder if there's any conversation around these questions that we could have now. Or Carlos, have you received any written chat questions?
Nothing in the chat. I guess there's what we might be able to do is open it up to others to ask questions.
Can you use the hand signals, guys? And if your hand signal comes up, I might be able to see that. Actually, you know what I'll do, because I can't see that easily, I will go on to the very last slide, then I'll get rid of this share screen. So from the case study and leading from assessment to treatment, of course, there's the intermediate stage of clinical reasoning. I'm going to add that to next week. Oh, no, I won't. I'll do that right now. I'm going to share the screen on just a clinical reasoning diagram that I want you to utilize something like it while you look at your vulvodynia case study next week. I apologize for the small print here, but the 5 headings that I put on the slide: screening, assessment, diagnosis, treatment plan, and reassessment are across the top. And in each of the columns in this table, we have what might go into those. So let me just read the blue top line headings in case you can't read it. So in screening, we would use pre-consultation patient questionnaires to decide if there's other triage necessary to get some outcome data. What we spent most of the time on in this session is the assessment: your symptoms and history, your signs, your simple tests, your palpations, and other investigations such as UTI tests or vaginal swabs, etc. The next thing, diagnosis. From all of that information, you make some hypotheses, maybe of primary and secondary diagnosis, and that's where the clinical reasoning comes in. Before you then go on to assess the patient's goals, what does the patient want? And combine that with the history you've taken and your diagnosis, your primary and secondary diagnosis, create the treatment plan, implement it, and then reassess later down the track. So I'm sure you all do that intuitively, but it's always nice to revisit it, because even when you get a complex patient with lots of things in each of the points of the triangle, it's still a very linear process going from screening to assessment to investigations to diagnosis to goal setting to reassessment. So always think linearly, think step-by-step process so that you don't miss things along the way. And I know if I do sound very prescriptive there, and like, I know all that. I'm a clinician. What does she think? Don't get in a huff. Just please, I really just want this to be, we all do all the time. So now I'll get off screen share, and we've got about 5 minutes or so for some questions. Eddie, I can see, was that your hand up? Unmute yourself.
Yes, as to whether you think with some of these clients with pelvic pain that is more less abdominal and more pelvic, do you think there's a role for both a pelvic floor physio who can do these sort of examinations as well as a more general physio in the assessment, given that a lot of the information is quite sensitive and personal? Is it worth, say, for instance, me in the pain clinic doing some of these preliminary assessments before referring to a pelvic floor physio?
Yes, it probably would, because you would be the primary physio and it's your team that's managing the patient. But if you're not skilled or qualified to do an intimate examination, then you certainly need that person. Whether that person comes first or second, I'm not sure that it matters all that much. but your team would be the managing team.
Okay. You don't think that there's sort of too much of an overlap or over assessment if someone's going to do a more thorough assessment than, say, what I would do?
Look, it depends on the patient, I guess, but a true chronic pelvic pain patient, would you be able to sort out the regional problems like the bladder problems, the bowel problems, or would you need someone else? What's your skill set? It's not too much of an assessment if those problems are an issue for the patient. She can't sit through a full lecture at uni because she needs to go to she's got this urgent feel all the time, or she's really constipated and her abdomen's bloating. Do you know how to deal with that? If you don't, then you need the pelvic floor physio.
Okay. On that, Marg, so I guess, probably part of, Eddie's question is, when do we refer to like a, chronic pelvic pain clinic, and when do we keep those clients?
Yes, a tricky one. And the answer is, as always, it depends. I guess, this is a harsh thing to say in one sentence, but was it the correct place for the referral in the first place? Should that patient have gone to a chronic pelvic pain clinic in the first place, and should the whole referral switch to another clinic if it's not really your skill set? Maybe you're better at the musc and neuro pain, and the pelvic gynae pain heads over to another clinic.
And I guess that sort of feeds into what you were saying before about that correlation between that sort of psychosomatic thing, and last fortnight we spoke with a psychiatrist, and he had said that there was BPD, 1/3 of clients, of chronic pain clients were BPD, and then there was a huge correlation with polycystic ovaries. So I'm just thinking, like, because there's just so much blend and complexity, is it worth sort of let's say we had a referral like that, which we do, we get multiple referrals from gynae that I've sent you. Do we take on that one aspect of the pain management, and then also obviously refer out to the like a pelvic pain specialist as well? Anyway, it's probably a question based on what that person's specific needs are.
Yeah, do you know what I would I think that maybe rather than think diagnostically like this, treat the pain, and if the pain is being managed holistically, then you're managing the patient, and then move them to another clinic if they have some issues that haven't been able to be addressed by your clinic. But this is this switch in your head as to pain is the major thing that you're treating. And then, but it's tricky, isn't it? And I guess that's why you don't have an answer yourselves.
Yeah.
I think if you don't mind me just saying, I think that triangle would really help with that as well. I really like that triangle model that you were sharing, and I haven't used that in regards to pelvic pain before. But I think that, if you can differentiate between, I guess, where the main issues are coming from, that might also help determine whether this is the right place for them at that time, depending on what are the bigger factors, and what's already been addressed and what hasn't been addressed. I quite like that way of looking at it.
That's a good point then, Michelle. Yes.
Sorry, there's a lot of background noise here. Yeah.
That's fine. If the volume from one of those corners or the mathematical circle is too large from one end, and you think, oh, this is all local pelvic floor stuff, then maybe this isn't the right place for this referral. I don't have those skills. Versus if it's in the regional area where I can manage all that. it may be the referral stays with you.
Yeah, I think it's a fantastic way of looking at it, and that might help guide our decision making from there.
Have we got any other questions? I think we're running out of time for this session. Any other pertinent questions for Marg? Okay, if that's the case, what we might do is we might, we've got our homework to do, Marg, so you'll be providing us with that homework. I think she's frozen again, but I guess, oh, there she is. So we've got our homework, Marg. And
yes, you can pass that round to everybody, please.
Thank you so much. What I'll do also is I'll collate questions from this session and get them to you as soon as possible, and that might give us a sense of where we want to head with part 2. And did you want us to do anything else for homework?
No, but what I would like to do is to hear from the medical and psych clinicians who are with us to see what they think, or what if they got any questions, because as I said, it's a very physio-focused talk.
I think Sue, the health psych, has to go.
Okay.
And I think Jeremy's just come back in. Louise is here. Louisa, if you have any questions. Also, Gloria has left, so Louise is the only one representing medical.
Okay.
Yes. Hi, Margaret.
Hi, Louisa.
Thank you for this interesting talk. So we do see, well, I do see some pelvic pain patients as well. So it is interesting to know how you, as a physiotherapist, see how you go about treating these patients. So I'll be interested to see what next week's talk is about.
Okay, fine.
Thank you.
Thanks, Louisa.
Thank you, Margaret.
Okay, well, look, if I can see people do have to go, so I won't hold you up any longer. Thanks for listening, and I look forward to you having a go at this case study, and I look forward to seeing you next week. Okay, have a good week.
Thank you very much.
Nice to meet you all.
We'll see you next week, everyone.
Okay, thanks, Carlos. We'll be in touch during the week, you and me, okay?
Yeah. All right.